If the foot's too big, forget about your thumb, just get that point back there. Okay, so there's a little part of the talus that sticks out. And then you reinforce with your other hand. This hand comes on the side. The patient should be lying back, but he's sitting up so he can see. That's okay. And then you put a little bit of preload towards the floor, you lean back, and then you fire. Okay, and this should, again, usually doesn't make cavitation, but you will feel the joint gap, and then you'll have improved dorsiflexion and tucking of the talus. Okay, the next one. So that's a really important one, star that. That's highly likely to be asked, and it's clinically the anterior talus. Okay, and then the, I'd say the second most important are the calcaneus. So it can be either posterior medial or posterior lateral. On both of these, you just change your hands around. So if it's a posterior medial, my medial hand grabs the calcaneus. My other hand cups over the top. The patient again should be lying down, but since you need to see. And then it's a pull. So it's a pull with a torque. So it's like I'm going to bang my elbows together on this one. Okay? And again, you won't often feel a cavitation. I mean, you won't hear a cavitation, but you will feel it move. And then we have the lateral version of this. And then you can also tap on it, okay? But we probably won't test on that. So anterior talus, posterior medial calcaneus, posterior lateral calcaneus. Okay, also from this position, we can get anteriority or superiority of the either the navicular or cuneiforms by doing interlocking finger job. Okay, so whatever I want to set up on, I can get. The exception being the cuboid. So the cuboid is going to be pies-form contact with fingers holding on, stabilization on the calcaneus. And this is one where you really don't want to blow it up. Okay, so you can hurt someone doing this one. Superior cuboid. Okay, let's, and of those, the three really important ones were the calcaneus and the anterior talus, so all those are fair game. For the inferiority, we have the patient prone, or let's have you standing with one leg on the table. So let's just stand up, face away from me, please, and then put one leg up on the table, and then we would need a rolled up towel. So sweatshirt would work if we can borrow that. Okay, so let's have you put your whole foot up there on the table, so move forward a little bit. Okay. So you need enough of something rolled up to prevent the ankle from doing this when you thrust. Okay, that's the point of the towel. The what we're going to hit here is either the navicular or the cuboid. So it's an inside-out adjustment. So if it's navicular, I'm going to use my inside hand, and I'm going to stabilize distally. So this is an odd one. And then I can be standing, and I do a thrust with this hand with a little bit of shear from the other hand. So it's inferior navicular, which is rare. Or I can do a cuboid, inferior cuboid. And this one I'm going to angle out a little bit. The navicular is pretty much straight away. This is angled out a little bit. And again, I'm going to bend the foot over my contact and then do a superior and slightly lateral thrust. Yes. So he's calling the top of the foot the anterior aspect, and this is the posterior aspect. So in anatomic position, typically the foot is plantar flexed, the way they laid out the adapters. Okay, what else we have there? We have a couple other foot things. Let's have you turn over again. These are of minor importance. So we have the cheers adjustment where we have a drop mat head, where you just pick up on the mat head. And then we have the adjustment for hallux valgus. How does he have it listed there? Does he have it on there? Tarsal, is it the tarsal metatarsal? Yeah. So was Frank joint. So on this one, the patients want to lie down for this one. So when you put your thumb in between the metatarsals, so I just showed this on the first. You bring your thumb up here, you put your pisiform next to it, you roll the leg, and then you thrust that way. So this is more of an advanced one, so let me just say I won't test on that one. Okay, but you should take a look at it. You might be on Walt's in front. Okay, and I think that's it for the foot, right? Okay, so then we have the tibia, the fibula rather. So the fibula can be stuck anterior, posterior, or inferior. So just bring your heel just off the edge for me. Did I miss something?
Did you do posterior?
I did not do a posterior talus, because I really don't believe in it, but okay. Another difference I have with Walt. So a posterior talus. This was his miracle cure when he was in chiropractic college, so he's never going to stop doing this because it was miraculous for him. So on this one, we're going to, because the talus is posterior and we can't really get to it, we're going to push the tibia back on it. So your contact's going to be the tibia. It's going to be a soft piezoform contact, and then just with reinforcement, or you can use this hand on the foot. You rock the ankle till you feel the right spot, and at that point you do a thrust along the joint line of the collarbone, straight back. Okay, fibula. Distal fibula can be anterior or posterior. It kind of nestles in this concave facet on the tibia. So what I want to do is I want to brace, if it's anterior, brace the tibia with my inside hand, and then my piezoform is going to be just above the malleolus, about here, about an inch above it. And I'm going to stand up, and I'm going to bring the back of the joint line parallel to the, perpendicular to the floor, and then I'm going to thrust A to P. And for an anterior fibula, and then for posterior fibula, do the same thing with the line prone, and the toes pointed in instead of out. Another fibula adjustment, if it's inferior, that is, I don't feel it moving up when I dorsiflex the ankle. I don't feel it moving up, lining up when I dorsiflex the ankle. I go into what's called the patient goes into the bikini pose. So you're going to lie on your side, face it that way, please. Bring this involved leg forward. This was all inspired by when Walton saw Burt Reynolds posing naked in some woman's magazine. It was like, why was he lying like this? So his leg would cover his penis. And we would pillow. And if you know who Burt Reynolds is, like he's the hairiest guy in the world, so it looked basically like a gorilla. Move back a little bit. Move back. You want this leg to be flat on the table. So this is a really good adjustment. This is for an inferior fibula. It's a two-hand adjustment on the inferior and superior aspects. The leg feel okay there? Yep. Okay. So I'm going to catch the inferior fibula between my thenar and hypothenar eminence. And then the proximal fibula, I'm going to always push it this way, whereas my main hand down here is going to push either straight up or a little bit back or a little bit forward. So Walton calls this the 5 to 11 or the 7 to 1. This is 6 to 12 on a clock face. So I might go straight up. I might go towards 1 o'clock. I might go towards 11 o'clock. This hand's always the same. And then from the same position, you can do mobilization of the interosseous membrane. So if I stood over there, got my thenars, or in Walton's case, thumbs on the interosseous membrane, I can do little thrusts. And if I was Gary, I would go. Okay, so anything else on the fibula? Okay, so I think you might have shown the posterior fibula, but I'm not going to test on that. Okay, let's go to the tibia. So lie your back, please. You didn't record, you recorded me saying bad shit about Walton. Erase that part, please.
Don't worry.
Dr. Walton, you are all powerful and always correct. In Walton's world, I wouldn't want to get caught in there. Okay. It's like a Twilight Zone episode. So, for the tibia, we have rotatory distance. So, the tibia The medial side can shift forward or back, and the lateral side can shift forward, or back. So the listing that we find the most is anterior on the medial side, or anteromedial tibia. So to set up on that one, what I would do is use 2 blocks, SOT blocks, or you can buy these really cheap biophysics, ugly navy blue biophysics blocks online. And so this is a setup for a tibia which is on anterior and medial side. So I put this inferior block so it's going to roll down the block or go back on the medial side. The block should be just above and below the joint line. This could be done on the drop table. So one likes to do this straight away. So you can have a pisiform contact on the tibia, and then get stabilized on the femur. I usually don't do it this way, so it feels awkward. And then you just drop with both hands. I like to do it straight away. It's just my preference, because I feel like you get more torque this way. So I just drop straight away that way, or you can do it on a drop. Okay, so you should definitely get some blocks and practice doing this setup. So this is what, start of this one, this is going to come up. The other tibia adjustment is in the bikini position again. So I want you to go sideways, and then if I can borrow the sweatshirt again. So the involved leg is now the posterior leg. So this is for a lateral tibia. And what I do is I'm going to bolster up the tibia, and then I'm going to stabilize, and then I'm going to do a thrust on the femur. Okay, so the thrust is on the femur. Does that feel okay? You straight down on the femur. You also do this on a drop piece, and the towel or the sweatshirt in this case pushes the tibia lateral to medial. So we're thrusting on the proximal bone on this one. Okay, and the last one under me, I believe, is the patella. So patella adjustments also is a keeper. You should start this. This is going to come up. The trick to doing this right is to lift the patella. So you want to get your fingertips underneath the patella when you do this. And I'm going to be in somebody's way, no matter which side I go to. So I'm going to lift. I'm going to lift with my right hand. This is a superior patella. And then I'm going to get some fat pad between me and the bone, because if I hit the bone, that's going to really hurt. And my forearm is basically dropped down onto his thigh. And then I would lift, see if it feels okay with the patient, and then I can do a pretty substantial thrust, and it won't hurt as long as you're lifting the patella. You can also do this for patella baja, but that's a lot less common. You just do the opposite here, again with the lift and the back pad. But most of the time you find a superior patella. I think that's it for me. Okay, so hip. On the hip. You should all be able to do this quick release. Does Aaron have a name for this one? He's just looking for decreased internal or external rotation, and believe me, when you go out there in the world, this is the deficit. Okay, most people are going to have decreased internal rotation, and so you want to not hurt yourself on this. I want to use my body to pick up. Oops. Sorry. I'm going to get behind the trochanter. I'm going to lift, thrust, and do that 3 times, and then recheck. So you've got increased motion. If not, I would do something more aggressive. I could do an arm bar. Move it around this way with distraction. Again, trying to use your legs. I could do some jiggling and maybe a long axis distraction, hard to do for faster. Or I can do the ultimate Walton, which is scouring, where I look for the catch, the elusive catch. And when I find the catch, I would do a thrust through the long axis. We do end up dropping